Hello, I am William, a thoracic medical oncologist at Grupo Clínicas, and I have here with me Dr. Mark Awad. He is associate professor at the Dana-Farber Cancer Institute. We've just had the presentation of the ADAURA study in the plenary session at ASCO 2023, and I have the opportunity now to get the insights from Dr. Awad about what he thought about the clinical study. So first of all, Dr. Awad, do you think this was the most important clinical study presented at ASCO this year for lung cancer?
I think there's a lot of great data coming out, and I think we saw also the Keynote 671 study, which was the perioperative immunotherapy study for patients with resectable lung cancer. So similar theme as, how do we improve survival for patients with early stage disease? And so I think we're seeing amazing results from both immunotherapy clinical trials and now with the ADAURA study, seeing that targeted therapy plays an important role in patients with resectable lung cancer. So I think these are practice-changing studies. Keynote 671, of course, did allow some patients with EGFR mutant lung cancer to enroll, and so we'll have to also decide how best to treat patients with EGFR mutant lung cancer. Do they get neoadjuvant chemoimmunotherapy? And then adjuvant ADAURA, osimertinib. We have to be careful with those patients just because of the potential overlapping toxicity moving from immunotherapy to targeted therapy. So this is something else we'll have to sort out. But I think the ADAURA study already was very practice-changing. I think it, as Dr. Solomon said, is practice-affirming for us to use adjuvant osimertinib for patients with EGFR exon 19 deletion or L858R mutant lung cancer after surgery. So
there were some countries still that don't have it reimbursed, and in Brazil, even though it is approved in the adjuvant setting, it still hasn't made it to what we call the ANS list, which is the list that requires the insurance companies to reimburse for osimertinib. Do you think that with this presentation demonstrating 50% decrease in the risk of death with osimertinib adjuvant therapy, is this now a standard of care set in stone? What's your takeaway from this?
I think it should be. I think with early stage disease, a lot of people ask the question, do our interventions help people live longer? Yeah, I think that is a really critical endpoint. And there was a question with ADAURA or with other such adjuvant trials, are you just delaying recurrence? And if people recur who receive placebo or who are on the control arm, can you rescue them by then administering osimertinib at relapse? And I think many people were waiting for the overall survival data to determine whether this should be a standard of care for patients with EGFR mutant resected lung cancer. And I think the presentation today says that, yes, we need to be using this as a standard of care. It not only prevents improves disease-free survival and prevents recurrence, but it helps people to live longer too. So I think hopefully the data presented here will lead to changes in practice and reimbursement for patients across the world.
So in the presentation here, we noticed that only about 40 to 50% of the patients received osimertinib that were on the placebo arm later on, right? Do you think that this impacts the way that we interpret these results? Do you think that maybe if we had crossed over everybody, we should see less impact on overall survival or no impact at all? Or do you think that this was the way that it should have been done?
Yes, I think, crossover is always an important consideration, especially with overall survival analyses. And if patients cross over onto the therapy that was used, does that kind of dilute out the overall survival benefit? And this was a large global study conducted in many countries in which osimertinib may not have been available at the time of disease progression or relapse. But I think the difference in disease-free survival, the difference in overall survival, I think is quite strong with these presentations that it could be hard to repeat such a study and build in 100% crossover to osimertinib. So I think these are the best data that we've seen and that we have so far. And I think it's important to incorporate what we have into today's clinical practice. So I think it's a really important finding, and I think hopefully it will lead to changes in practice in more parts of the world.
It's about, the absolute improvement in survival at 5 years is about 10 to 12%. So how does that compare with chemotherapy? And do you believe that this is a clinically meaningful improvement in overall survival?
Yes, I think so. We talk about the risk reduction of adjuvant chemotherapy about 5% at the 5-year time point. Because the prevalence of lung cancer is so high globally, and we heard as a reminder, lung cancer is the leading cause of cancer-related death worldwide. I think even a 5% risk reduction in survival translates to thousands and thousands of lives saved, hopefully. So 10% overall survival benefit is extremely meaningful. Again, EGFR mutation, positive lung cancer is very prevalent across the world, and especially in certain parts of the world, can be up to 50% prevalence. So I think that survival benefit is very important and meaningful, not just a statistically significant difference, but truly clinically meaningful.
And in the ADAURA study, adjuvant chemotherapy was not mandated. Yes. So it was at the discretion of the treating physician to deliver adjuvant chemotherapy and then go on to placebo or osimertinib. Do you think that we're ready to omit adjuvant chemotherapy for these patients?
I think we're in a fortunate place now where we're not only asking the questions, how do we intensify treatment for patients that aren't going to do well, but how do we de-escalate or de-intensify treatment for patients that don't need as much therapy? And I think that the study wasn't necessarily powered to ask the question about did patients who did or didn't receive chemotherapy, was there a meaningful difference there? There was probably a lot of selection bias as to, as was mentioned, about 60% or 2/3 of patients did get adjuvant chemotherapy, and we don't necessarily know all the characteristics of who did or didn't receive chemotherapy. So I think it's an important discussion. I think some patient preference was involved, some physician discretion was also involved in these decisions. So I think it will again be a shared decision based on who might be a candidate for chemotherapy. But we did see historical data showed an improvement in survival with chemotherapy, now with osimertinib. So I think it may still play an important role for patients, but it will need to be something that's discussed between a patient and their physician.
And would you offer osimertinib for all stages that were included in the study, which is stage 1B, 2, and 3A according to 7th edition?
I would. It'll be important, of course, to see some subgroup analyses, but I think thus far it seems like the placebo arm in ADAURA, it just shows that our standards of care were not very effective, and we would see high rates of relapse in all of the stages that were included. So I think for now I would include osimertinib as an adjuvant therapy for what was stage 1B to 3A, the staging system with the AJCC 8th edition. But yes, I think without adjuvant osimertinib, there's still a high risk of relapse even for the very earlier stages. So I would offer it.
Awesome. And Mark, what do you think are the future questions that we need to answer in this field? EGFR mutant disease, resectable disease?
Right. I think we need to understand who are the patients that, and is there anything else that we can offer or intensify therapy to improve the cure rate? Are there some patients that are already cured with surgery and or adjuvant chemotherapy that don't need to take a pill for the next 3 years? So are there certain patients that we can sort of reduce the amount of therapy that they receive? The other big question is what should we continue therapy beyond 3 years for patients? Should this be a treatment? We look at the curves and what happens after the 36-month time point in disease-free survival or overall survival. Does that mean we should be extending therapy even beyond that time point? It's an important question. I think as was mentioned during the discussion, can we extrapolate this into other mutational subsets of lung cancer that are less common, in which the accrual to adjuvant clinical trials will take many more years of readout? Should we wait for those trials to read out, or should we be extending and extrapolating the results to other mutational subsets? That's an important question. Obviously, we want evidence to guide our therapy, and so hopefully this will spur enrollment to other adjuvant targeted therapy trials too.
All right. Well, thank you very much.
Pleasure.
Excellent discussion.
Thank you so much. Pleasure. Thank you.